Morning and welcome to this week's episode of the Ask Dr. Murphy series. I hope everyone is doing well today. My name is Katie Berg and I'm a research study coordinator here at the Havey Institute. I will be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Great.
Surviving the foggy and rainy weather here in Chicago. Everyone be safe with these tornado warnings. But getting back into the show, Dr. Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, public health, and infectious disease questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be reviewing headlines and COVID statistics through today, July 13th. We invite you to submit your questions below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Please feel free to leave a comment down below as well. Starting with the updated COVID statistics, average of about 10,000 new COVID cases per day. We're averaging about 888 hospitalizations per day and about 26 deaths per day. New booster proportion has stayed steady at 17%. Dr. Murphy, do you have any reactions to those numbers?
Yeah, no, I mean, they're still staying in the right direction, and this is great. 26 deaths per day is really low. We haven't had that since the very beginning of the pandemic. It's going in the right direction. Still hospitalizing a little under 1,000 people per day. That's bad, but they're living because there's so many treatments that are out there, and we really know how to take care of sick patients now.
Mm-hmm. Yes,
Now,
it's absolutely great news.
The booster proportion is staying the same. It's stuck at 17%. Now, it really kind of depends who's taking the booster. If it's the really high risk people, that's good. And I think that's who's mostly taking it. The other thing that's keeping that down is people are waiting for the updated vaccine that's coming out in September. Me and others are telling patients, wait till the new one comes out if you've already had the bivalent booster. So it's going to be a really improved vaccine. So this fall, you're going to have a new COVID vaccine, an RSV vaccine, which is available actually now or very soon, and your updated flu vaccine. So those three, sometime this fall, people need to take to prevent getting sick seriously.
Absolutely. We should all keep an eye out for when that new booster will be available. And speaking of the new booster, we have a lot of, COVID drug medical related headlines today. Getting started, there was a study very recently published about the role of Paxlovid in younger patients, 50 or under, with serious comorbidities. Can you tell us about the results of that study?
Yeah, this is a big study in vaccinated adults, as you said, 2,500 patients receiving Paxlovid compared to 80,000 vaccinated patients who didn't take Paxlovid. Now, Paxlovid is underutilized. So this ratio is not unusual, although this is a clinical study. But anyhow, so keep in mind, younger people not hospitalized, 2,500 versus 86,000, and they found that the all-cause hospital visits was reduced. The number of that's just like to the emergency room or clinic, whatever. All hospitalizations were reduced, and mortality in the first 30 days reduced. That's if you take Paxlovid in these vaccinated younger people. So that's very important. It just shows that the drug works. These antiviral drugs work great if you take them early in the course of the disease. Overall, there was a 30% relative reduction and a decrease in the number of patients needing further treatment. So, even less long COVID, basically, is what that means. Interestingly, in this younger kind of group, the risk reduction was shown to be significant for individuals with underlying cancer or heart disease. So that, of course, is a signal for, high risk. And those with only asthma or lung disease didn't really get any significant benefit from it. So Not that they shouldn't take it, but the big benefit was with anybody with underlying severe medical diseases like cancer and cardiovascular disease.
That's very, very interesting. And of course, as we get more research on these drugs, we'll continue to share the news that we are able to find. Another study recently on molnupiravir was just published. Could you tell us about those findings?
This is molnupiravir and Paxil came out about the same time. Molnupiravir is a different type of drug, but it is a direct acting antiviral. So anyhow, it's always been unclear how effective it really was. It does have, many studies have shown some modest benefit, but in this study in veterans, 2,900 veterans, half got molnupiravir and half got placebo. So this is a really well-designed, powerful trial because you have placebo control, all right? The patients and the doctors didn't know if they were getting placebo or the drug. That's the strongest kind of study that you can do. So, and then among the molnupiravir patients, 82% didn't have any symptoms at all right, but they got diagnosed. Probably somebody they were around had COVID, and so they got tested and they found out they had it. Only 18% had symptoms. And in the control group, it was 65% with no symptoms and 35% with symptoms, a little bit different. The overall median age was 69 and 92% men, typical of a veterans population. Additionally, 14% of the total participants had not been vaccinated or they had not completed the first 2 doses of the original series. 64% had completed a primary series of vaccination and received at least 1 booster dose. So they didn't see the results. They didn't see any significant difference in hospitalization or mortality within the first 30 days. However, if you then separate out the patients, the asymptomatic patients, in other words, no symptoms at all, they actually got a benefit. So that's not too surprising because the problem is the strength of the drug. It's not that powerful. So if you get it early when you don't have any symptoms, you probably don't have that much virus, a relatively less powerful drug will work. And it did. Yeah, so I mean, that's kind of the story. Molnupiravir still remains really, it's pretty unclear, how effective it is. It does work a little bit. And if you can't get the other one or you can't take Paxil, you would want to take that.
Absolutely. And it's very, very interesting information and a very interesting comment you just had there, which is the drug molnupiravir maybe isn't as strong that we've seen in clinical trials and that it may be better at knocking out a smaller amount of virus. So that's really good to keep in mind.
Yeah, it's just not, doesn't work that good. And people who are really sick have a lot of virus.
Mm-hmm. Speaking about people who have gotten very sick from COVID, there was a recent study published about certain parameters for early recognition of certain severe side effects linked to, those severe conditions in adults. Could you give us a little more context about what that really means?
Yeah, this is a study in over 10,000 patients who were hospitalized. And they found, and this is a relatively young group with a median age of only 30 years of age. And they got multi-system inflammatory syndrome or in adults. It's often referred to as MIS-A, all right? And this is similar to the kind of syndrome that younger kids get, but these are older, these are adults. These are young, predominantly young adults. And so what happens is these people get hospitalized. They don't have the typical pneumonia, but they have all these other systemic problems. They have problems with their blood counts. They have elevated measurements of their inflammatory markers. They're hospitalized. They're very sick. And of all these 10,000 patients, there's only 53, so it's not very many, got this syndrome. But if they got it, they got really sick. And, 90% severe cardiac disease, 81% gastrointestinal symptoms, which oftentimes is not thought to be due to COVID, and 77% shock or hypotension. This is serious stuff. In general, patients with this syndrome had the infection 3 to 12 weeks before they finally got admitted to a hospital. So it comes on kind of like slowly. And it's a rare complication of COVID. But it has a very severe presentation and hospital course. And they have long hospitalizations, and they get multiple studies and all sorts of interventions. So it's just something to be aware of, because as the cases go down, these younger adults can show up and like, what do they have? They could just have this syndrome.
Absolutely. And
Okay.
there are a lot of studies and subjects that have been looking towards the effects on older populations, because we know those people have been most at risk historically with
Right.
COVID-19. So it's really interesting. Yeah.
Good point. And they remain mostly at risk, but younger people still can get this unusual syndrome. And I think it's just a footnote that when people come in with these, these people are sick, they're hospitalized for a long time, that it could be a COVID-related phenomenon.
Absolutely. Something to keep in mind. And switching to hopefully a little bit of a lighter note, there is new research that was published via Stanford Medicine about a possible new COVID vaccine. Could you tell us a little bit about it and why new COVID vaccines are really even being developed when we have such great ones so far?
Yeah, so there's multiple vaccines around the world. In the United States now, we really just have 3 because Johnson & Johnson has withdrawn. That was the fourth one. So we have the Pfizer one, the mRNA one, we have the Moderna one, and we have Novavax, which is a more traditional protein-based design vaccine that are approved. Those all work just fine. This is a new one. So why do we need a new one? We already got 3, 2 different kinds. The reason is that this is an older technology that uses aluminum hydroxide as an adjuvant. An adjuvant just makes the vaccine work better. It's not an active antiviral. It's not an active part of the thing. It just makes the vaccine work better. That's what they call adjuvant. So anyhow, it's used a lot, safe, inexpensive, and this vaccine can be produced in very large quantities. So it's cheap and it's stable without refrigeration. So if you have to be in a place where you have problems with refrigeration, keeping things, super cold or even in the refrigerator, this thing is going to have a very high impact for people that need the vaccination. And that's why it's kind of exciting. So now it's only been tested in monkeys. So we forgot that part of the study. But if this pans out and succeeds in human trials, it could be a really great alternative than these very expensive mRNA vaccines. And it's an older technology, and you don't have to refrigerate. It can be on a shelf for a long time. And it would be a big advantage as long as COVID remains endemic, which we expect is probably for a very long time.
Absolutely. And of course, while vaccines will still expire, knowing that there's, not the drawback of having to keep your samples way freezing during the meantime and shipping is
Right.
Really a big logistical help with this new vaccine.
Right. We'll see how well it works. Yeah.
Absolutely. We'll see if it gets through human trials. That'll be something we'll keep an eye on.
Yep.
Well, I wanted to thank you very much, Dr. Murphy, for your time and expertise on these headlines and the COVID statistics. We really appreciate your time.
Great. Thank you, Katie.
And thank you everyone for joining. Please remember to submit any questions you have below or via our Facebook or email. They will be linked in the description. Thank you again and have a great day, everyone.
Great. Have a nice weekend too.